Emory Midtown. All right, well, I think we've got critical mass in the room, so we can go ahead and get started with our very special guest today. So we are really pleased to be hosting Dr. Neha Vapiwala, who is Professor and Vice Chair of Education in the Department of Radiation Oncology and also Dean of Admissions at the Perelmann School of Medicine at the University of Pennsylvania. Dr. Vapiwala is internationally recognized for her management of patients with genitourinary cancers and was the department's first chief of GU Oncology. Her research interests focus on biological and technological improvements in radiation therapy, molecular imaging, and integrative medicine for disease and treatment-related symptom management. She's the PI of multiple therapeutic trials for prostate cancer, including an NCI-sponsored randomized phase 3 cooperative group trial that's exploring the use of PET-directed therapy in patients with recurrent prostate cancer. She served as a project leader on a DoD program project grant investigating particle therapy and also holds leadership positions in multiple national societies and cooperative group committees in GU Oncology, currently including the NCI Prostate Cancer Task Force, the ECOG Akron GU Early Modality Committee in the role of co-chair. She's an elected member of the board of directors of ASTRO, the nominating committee of ASCO, and on the editorial boards of JCO and JAMA Oncology. In addition to her work in GU Oncology, she is a well-recognized leader in both undergraduate and graduate medical education. Her efforts have focused on the critical importance of enhancing socioeconomic, gender, and racial diversity in the medical workforce. And prior to her role as Dean of Admissions, she was the Assistant Dean of Student Affairs. She also served a 6-year term on the executive committee of the ADROP, the Association of Directors of Radiation Oncology Programs, and just concluded a 3-year term as chair of the ACGME's Residency Review Committee for Radiation Oncology. She joins us after having completed her undergraduate degree with a double major in biology and Hispanic studies from Hopkins. She taught high school math and algebra before she matriculated at UPenn, where she has been on faculty as a resident and then on faculty. And we are so excited to have you here as our visiting professor. Welcome.
Thank you. Good morning, everyone here and also joining us virtually. And thank you, Dr. Joxie, and congratulations on being the chair of this incredible department and this facility that I am in awe of, in addition to everything wonderful that Atlanta has to offer. So I'm so grateful to be here. My husband actually went to Emory undergraduate, so I hear lots of fun tales from a time a while ago. But so it does feel like home in many regards in that sense. So I'm really pleased in particular to be able to share with you not only some of the history that is behind the topic that we'll discuss today, but some of the work that's ongoing, not only work that I've had the pleasure of being a part of, but that many of our colleagues in the oncology space are working on. And so I think it's an important opportunity for us to reflect on that and see what other directions we still need to explore. So with that, I'll get started and have no relevant disclosures. So at a press conference 57 years ago, the following words were said: "We are concerned about the constant use of federal funds to support this most notorious expression of segregation. Of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death. I see no alternative to direct action and creative nonviolence to raise the conscience of the nation." And many of you may know who this quote is attributed to. It's Reverend Dr. Martin Luther King Jr. And he spoke these words at something called the Medical Committee for Human Rights Convention in Chicago, Illinois. So the Medical Committee for Human Rights, those of you who may not be familiar with the history, was actually a group, essentially a group of volunteers, many of the founding members of whom were physicians from private practice, from academia, who were from the North and who banded together in New York. And their job was essentially to be a support group, if you will, for civil rights workers in Mississippi at that time. And so they traveled from New York to Mississippi, essentially helping to register voters, helping to teach in schools, helping to educate and work and volunteer in hospitals. And it was this movement really that was part of the obviously very long process of the civil rights work that was ongoing at that time, that led to this continuation that, hey, we're this group of people who banded together. We made all of these colleagues and friends who we've supported in the South. We should meet on a regular basis, and so was born the convention. So anyway, just some history there of why this conference was taking place and why this press conference in particular was focused on medicine, because the founders were physicians. And I want to go through the words I highlighted in blue for a reason. Notorious expression of segregation, what is he referring to? So at the time, virtually all hospitals in the United States denied access or provided substandard care in substandard rooms to Black patients. And you could argue at the time that, well, perhaps this was just, leftover, and this was because of lack of regulation, lack of, any laws that would allow for this to happen. Well, in fact, this was in violation of existing laws at the time and was still continuing. So in 1963, there was actually a Supreme Court ruling that struck the sanction, essentially a Jim Crow provision that said it was okay to provide separate care. And this was essentially something that was inserted in the bill by a congressperson, last name Hill, of the Hill-Burton Act, who was a segregationist. He was a Southern Democrat segregationist. And he said, you know what, it's okay. We can use federal funds to build hospitals in neighborhoods that need them. That's what the Hill-Burton Act provided for. It's okay to use federal funds, and it's still okay to have separate hospitals as long as we still, can say or pretend that we provide access. So, this was really essentially something that was struck down in 1963, but the practice of the segregation still remained. 1964, we had the Civil Rights Act. 1965, we had Medicaid and Medicare legislation that, again, ensured that federal funds were only channeled to hospitals that were providing equal access to all patients. And yet, as I said, the speech by Dr. Martin Luther King was being made years later. So clearly, this expression of segregation persisted despite the rules that should have prevented it. When he says injustice in health, what does he mean? Well, again, we're very used to hearing these words, injustice and health, but notice that he used the word health, right? He didn't say health care. And a lot of scholars have actually, purported that perhaps this was a very intentional use of the word health, because before it was in vogue, or perhaps before we all really thought about it in the way we do today, really a reference to the social and economic determinants of health that go beyond the physical. And so to use the word health was very much an intentional word to encompass these myriad determinants. When he says the words most inhuman, this also has been studied and thought to be a very deliberate choice. He's not saying inhumane. This has actually been, in some reproductions of this quote, a typographical error. It was very much inhuman. That's the word he used. Because you can see the distinction between what it is to be inhumane versus what we mean when we say inhuman. A denial of humanity so egregiously cruel that it is and should be beyond human action. And also at this convention, I want to point out a quote from Dr. John Holloman. Dr. John Holloman was a practicing Black physician from Brooklyn, New York, who was part of the founding group of the medical rights of this convention. And he, along with his colleagues, the very few Black physicians who were practicing at the time, noted that it's not just about the patients, right? There's scarcely a hospital, north or south, that does not overtly or covertly discriminate against Negroes, but that county medical societies have discriminated in admitting qualified Negro doctors, and very much in his quote attributed this right to the American Medical Association's doorstep. Again, this was part of a larger conference that was really speaking out against the AMA's lack of action, if anything, in addressing the workforce. So I give you this background because I want to just, again, focus on the last part of Dr. King's quote, that there's no alternative to direct action and creative nonviolence to raise the conscience of the nation. And we're going to try today to talk about the complex etiology of health inequities, including, the role of implicit bias, as well as overt racism, and just really try to demonstrate the multifaceted impact of health inequities on individuals, on society, how it impacts our specialty and beyond, and really to also think about options, solutions, programs, initiatives that we can all be a part of so that we're not just describing the problem. And I've always said, it's great to be problem aware. People often say problem oriented. Be problem aware, be solution oriented. So this is a picture that you may have seen. I'm sure you've seen many, many versions of this. I like this one in particular because I think it really does point out that the fair and just opportunity for every individual to achieve their full potential is what we're striving for. And so you have to account for what's the baseline. And if we're always focused on just equality, we're not necessarily adjusting for the differential baseline. And equity is great. That's what we're striving for, but it can be daunting because the reality is so far from that. And so that's where I think we need to really focus our efforts. So let's start with an example for the ages, right? It's impossible to talk about health inequities and not talk about the elephant in the room, literally, right? The COVID pandemic, as I just took off my mask. And we've seen these data in various, shapes and forms. The cumulative COVID-19 age-adjusted infection rates by race and ethnicity. I'll allow you to venture a guess at what's behind the blue bars, but I think most of us know that the higher blue bars, unfortunately, do represent individuals who identify as people of color. We have our Hispanic population in particular, the third bar, and our Native Hawaiian and other Pacific Islander on the far right as actually the most impacted by infection rates. And then if you superimpose on this death, so mortality rates from COVID, you can see again a stark difference and dramatic difference compared to white and Asian populations in the US, particularly for Black and Hispanic, but really striking for our American Indian and Alaskan Native population. So I think we're all aware that this has really laid bare existing inequities. And so I would argue, and you're going to go through with me on this little journey of all of the ways in which health equity matters and why it's an imperative. So first and foremost, I'd argue it's a national imperative. And these are US life expectancy data at birth, most recently. So these are, 2021, published in 2022. And you can see by race what the life expectancy is. But I think what's really important here, it's impossible to take this, at a point in time and make much of it if you don't have context. And the context you need is what is the decline? And just relative to 2019 alone, this is in red, the decline per group. And what I really want to point out is that for Alaskan Natives and American Indians, the life expectancy that fell 6.5 years, the life expectancy of 65 years, just to put it into context, is what the average life expectancy of an American was in 1944. So these are data that are from just recently, and obviously the pandemic, as I just described, has played a big part in this, but it really is a concerning trend, and we have to also query what is underlying this beyond the pandemic. So I'd argue it's a healthcare imperative, okay? Pervasive health inequities in the US, unfortunately, for a variety of reasons, fall most dramatically along racial lines. So if you look at non-elderly adults, 18 to 64 years old, often referred to as working age population, and all these data are compared to whites as if we take that as our baseline. And Black, Hispanic, American Indian, Alaskan Native patients are more likely to be obese. We know obesity impacts a lot of chronic conditions, among those asthma and diabetes. We also know that Alaskan Natives and American Indians are nearly twice as likely to have cardiovascular disease. They actually have the highest prevalence of COPD in this country at 12%. Blacks are more than 3 times and Hispanics 1.3 times more likely to have kidney failure. And Blacks and Hispanics have over 10-fold and 3-fold higher AIDS diagnosis rates, respectively. So again, to the extent that some of these conditions with then a pandemic superimposed contributed to the data I've shown thus far, it is important to note. But again, these are data that we've long known, and what have we done to address it? This is a cancer-specific imperative. Again, incidence and mortality differences among BIPOC individuals compared to whites have been described for years. These are just some of the stats that you are all probably very familiar with. We know that Black women, for example, at least recently, in recent data, have been shown to have slightly decreased breast cancer incidence actually compared to white women, yet a 42% higher mortality rate. We know that Black men have a twofold higher prostate cancer specific mortality. Black and Hispanic women for cervical cancer, which again, highly preventable, and if prevented early, don't even need treatment. The reality is that these women are at risk for being diagnosed at much higher stages, 14% and 22% higher incidence. And for, again, Alaska Native American and Indian individuals, increased likelihood of developing literally every type of cancer you can think of in most regions. And so they've been studied based on their regional, populations. And you can look all across the country, northern, southern plains, Alaska, Pacific coast, east and southwest, and you will see these differences striking. And perhaps a very interesting finding, cancer was the #1 cause of mortality in 2019 among US Hispanics, as opposed to heart disease, which is what we more commonly see in non-Hispanic whites. And this is thought in part to reflect the younger population of the former. And this is going to come into play about why the economic impact of this is so great. So again, bear in mind, as oncologists, who are our patients that need us the most and that will be needing us the most in the years to come? I would argue that health equity is a societal imperative, okay? We mentioned the reference that Reverend Martin Luther King Jr. made in his quote to health, not health care, because we recognize, and I think this is a beautiful quote that really captures that social determinants of health are not a footnote or a side note, but they are in fact the main issue. And this is, I think, a wonderful schematic that I encourage all of you to look at from the National Academies of Sciences, Engineering, and Medicine. Is there anything more humbling as we think about our wonderful drugs and our wonderful therapies than this, where the clinical care, as important as it is and as important as we are, is but a fraction of the impact that one will have on the health of individuals. And I think this is just a stark reminder. And again, you can disagree on the percentages, and these will vary for individuals, but the reality is that all of these things, everything from community safety, air and water quality, to tobacco use and diet and exercise, the things we more traditionally think about, are playing a role in what's getting your patient to a healthier state. And remember that drop in life expectancy I mentioned, where literally the life expectancy matches that of the American in 1944. I think this quote really beautifully sums up that from an individual who is from that community, Ann Bullock, who's a former director of diabetes treatment at the Federal Indian Health Services Agency. She points out just last year in this quote, in this article, there's nothing weird or unusual about our population. This is simply what happens biologically to populations that are chronically and profoundly stressed and deprived of resources. I would argue this is a financial imperative. Let's look at unemployment rates in the United States in 2021 by ethnicity. The bars speak for themselves. And why does this matter? Obviously, employment, in addition to the obvious, issues that can be associated with that and lack of access, also is tied to insurance access. And so when we think about our legislative imperatives, income, access to healthcare, even with the Affordable Care Act, we know that low-income adults are more than twice as risk of stroke and higher rates of heart disease, diabetes, and other chronic disorders than wealthier Americans. We know that Latino adults are the least likely to have health insurance of any major racial and ethnic group. I will point out they are also the fastest growing demographic in our country. And as I just mentioned, the cancer rates are the #1 cause of mortality, particularly because of the younger population. Now, I don't want to just make this doom and gloom. I said we would talk about solutions and be focused on that as well. There has been some recent good news just from a couple of months ago that coverage gains of more than 1% among adults in this narrow age band of 19 to 49, that non-English speaking Latino and Alaskan Native and American Indian individuals were the greatest of all groups. And again, this is because of efforts to really provide access through the Affordable Care Act. Let's look at location of residence and how legislation matters there. How does housing discrimination play a role? Well, a third of Black and Native American children and a quarter of Latino children live in high poverty neighborhoods. So high poverty neighborhoods is defined as 30% or more of households in that neighborhood, in that zip code, living at or below federal poverty lines versus 5% of white children. I will tell you, any percent is too high. So I'm not happy with the 5% either, but I do think it's a stark reminder of how it is that we can be focused on just treatment when you have all these other pressures facing these families, and really impinging on health, both for children and then the adults taking care of them. Over 50% of individuals who live within 2 miles of toxic waste, and this has been mapped, and you can look this up. This is looked at every year, are individuals of color. So again, as we think about cancer risks and exposures, this is a legislative imperative. This can be addressed through legislation. And again, on a good news front, there are a lot of efforts that the Centers for Medicare, Medicaid Services, through lots of communications, through state letters, are really trying to work with state governments and local governments to address these socioeconomic determinants of health, to remind individuals who are in charge of public health in their communities that there are organizations already in place providing health-related service needs. Are you utilizing them? Are you channeling your patients and your community members before they become patients towards these services for prevention? And as recently as January, there was a clarification letter issued to raise awareness of all these existing options that are well-funded, but absolutely underutilized. Moving through our imperatives, this is a radiation oncology imperative. Many of our colleagues have published and spoken on these matters, and I encourage you, if you haven't seen these publications or looked at them, to review them, to understand why there is so much concern, so much hurt, and to really think about how it is that we can be part of a community together and listen to each other and understand what we can do to move forward. And all of this, if I can't convince you through all of these imperatives, let's just be clear. This is sound economic policy, health equity, and striving for it. It's absolutely sound economic policy. You can look through every single lens and the business case is there. The projected composition of the US working age population by 2050 is absolutely majority individuals of color. And if you look at the pie chart on the right, you'll see in particular individuals Hispanic and Latino descent, as I mentioned, who are the least likely to be insured, who have the highest rates of cancer mortality, will represent a significant portion by 2050. And this also matters as those of us of a certain age continue to get older. We're thinking about working age to retirement population now. Remember, the working age people are the ones supporting those who are retired in our current structure. Right now, it's 3.5 to 1. By 2050, it's going to be 2.7 to 1. So the burden on each individual worker to support all these retirees, this is not sustainable. This is not sustainable if you have an unhealthy working age population on top of everything else that they're going to be facing. And just the numbers alone are staggering. These are not small numbers. And I'm throwing this out there, and I can go through in a great extent, but we don't have time, about how these data are done, but I strongly encourage you to look at it. This is based on US Census Bureau data, projections and models looking at gross domestic product in the United States, and they take potential increase in earnings under a model, if you will, a utopia of racial equity, where you don't have respective earnings that are less than white individuals. And if you were to adjust for that, so that's just one component, right? Income equality. But then what about the time lost from all the days called out sick? What about the actual expenditures in healthcare that were done at the advanced stage of cervical cancer instead of for the pap smear that could have been done for far less? So again, staggering data and really drive home the point. And this isn't just about the finances, but how business itself is conducted. There are two separate studies done by Deloitte Center for Health Solutions in 2021, double-blinded survey, as well as 28 in-depth interviews with leaders of health organizations in the United States asking them through these surveys and through these interviews, what are your strategies to improve health equity within your organizations, among your employees, as well as the communities that you're serving as a health organization? So at different stages in their health equity journey is the take-home point, right? So some are just starting to get involved, some are a little bit further along the line, but they all said it is a top priority. And whether or not this is manifest in what they're doing is a different story, but at least half of the CEOs surveyed did say it's at least among their top three. So they may say top priority, half said it's among their top three, all reported leadership and our financial commitment. So to me, that's the most important takeaway from here, because I think as we all know, how you spend your money is what you care about. And there is no better marker. It doesn't matter what they say. What matters is, are they investing in it? So there is hope that these health organizations and business leaders are recognizing this. And so there may be some change from within and across these organizations. As scientists, we need to be thinking about this, okay? In our science industry, if you will, the broad world in which we ascribe all of our medical advances. ASCO 2020 published this data, and this is not US-based alone. This is across international trials, and they looked at oncology trials, specifically actually immunotherapy trials, immuno-oncology. And the demographics of the patients enrolled are majority age 65 or older, majority white or European American descent, majority male, and you can see the relatively poor proportions of individuals who are non-white. And why this matters is that we are trying to learn about these populations. We're trying to do good science and have representation. And no better example, perhaps, than recently, our group looked at the AACR, American Association of Cancer Research, has Project Genie. This is a data set that is growing and currently across US sites has over 43,000 samples that are available for a variety of studies, and scientists are using this data set to make all sorts of conclusions about various ethnic groups. And we looked at specifically patient representation by race ethnicity across all cancer types and looked at what would be expected for the population versus what was observed. And so the ratio of 1, if you will, would be adequate representation, right? 1 to 1. And what we found is that patients who are white were overrepresented for all cancers except for lung and melanoma relative to what would be expected. And that's simply because what's expected for white individuals for melanoma is so high. Asian and Pacific Islander also very well represented in colorectal, lung, and breast, but Black patients were significantly underrepresented in all except melanoma, again, because the rate of expected for melanoma is so low, and for cervical. Hispanic patients were underrepresented across the board. And then our American Indian Alaska Native patients were significantly underrepresented. And I just got done telling you, they literally have the highest rates of practically every cancer that you can name, and yet we have no samples. And so if we're going to learn more about these patients, and yet they have these rates, they're presenting with more advanced disease, they're presenting with these cancers, and yet we can't collect the data, how will we improve and how will we consider the various factors that may or may not be along racial lines? Maybe it doesn't matter, but when you have scientists using Project Genie databases to make sweeping conclusions, we need to be mindful about how the underrepresentation may be skewing the results we're finding. And most clinical trial diversity initiatives are focused on patients, okay? They're focused on these individuals and trying to encourage them to be part of this. But perhaps the most important piece is that they need providers who are in the clinics, who are talking to them about enrolling on these trials, who perhaps resemble their background. That's been shown in multiple studies to be one key factor. It's not the only factor, but instilling that trust and promoting trust. And obviously, it would be a talk unto itself to talk about the history of medical experimentation and clinical trial, misbehavior, if you will, that has negatively impacted these communities and why the mistrust is there. But what we do know is that a workforce that understands the community's mistrust is important to building those bridges. And this is a wonderful publication I would encourage you to look at from the Red Journal from December 2022, if you haven't, that really gets at a variety of ways in which mistrust in clinical trials can be addressed. How do we move towards diversity in research? And I'm happy to say that this coming ASTRO annual meeting in San Diego is going to feature a session on this, chaired by one of my former residents, where I and others will be speaking about a variety of ways in which we move towards better representation in our trials. But the bottom line is, we can't get there without individuals in our workforce who understand and can help to address some of these issues. And again, you already heard this from me, that individuals of color are projected to make up over half of the US population in 2050, not just working age, right? This is now the entire population. I previously showed you working age data alone. And so it's worth understanding, is our medical school classes, our future physician workforce at all shifting as the population we're serving is shifting? So this is work we did analyzing the full-time faculty roster for 18 clinical academic departments over a 40-year time period. And we specifically assessed the percentage of women and individuals underrepresented in medicine per the AAMC definition, that's Black, Hispanic, and Indigenous peoples, among 4 groups. We looked at clinical faculty, full professor level, department chairs, and medical school deans, and then we used 3 time points over this 40-year period: 2000, the US Census at 2010, and the US Census in 2019. And what you see here, and you can see here, 0 is the bar that would imply that there's representation at each level that is consistent with the percentage of these individuals in the population. And so there's underrepresentation across the board. Okay, we know that. The question is, to what degree is this underrepresentation changing? And is it improving at all levels of academic progression in the hierarchy of medicine? You can see that women, in terms of underrepresentation, are most dramatically improved among the clinical faculty group here. And as you go further along the academic ladder, the underrepresentation is not only fairly staggering as we approach sort of minus 40% and higher relative to the representation in the US population, but also that it is not really improving much as you go across the chair and dean level. Unfortunately, for individuals underrepresented in medicine, I would say the data are stable or worse, meaning less representative over time. Again, we're not saying that we can get to 0 overnight, or that is even necessarily appropriate if individuals don't have an interest in medicine, if individuals aren't seeking that care. But to be this underrepresented and to be heading in the wrong direction as our population goes quite the opposite is really a reason to pause and ask ourselves, what is happening here and what are the practices? Is it that individuals are not applying in medical school? Or is it that they're not getting in? Or is it that they're not progressing beyond a certain point? And I will tell you, these are all individuals already who went through medical school, right? This is about the career ladder. This is about, why are they not progressing once they have already gotten in and moved along? Are they really not interested in leadership positions? I think you have a woman in this room who will tell you otherwise. So we have to ask ourselves what's happening here. And then within oncology faculty diversity is a critical step, right, towards helping those ASCO data, helping get better representation in Project Genie as we look to evaluate differences in certain cancers. And you can see here, AAMC data, we're doing great bringing women into medical school, actually over 50% female for several years now. We are making strides in our representation of Black, Hispanic, and sadly, even 1%, believe it or not, is something of a stride for Alaskan Native and American Indian individuals. But when you get to oncology, and this is just medical oncology, okay, but suffice it to say, you take a snapshot in 2022 at ASCO, and we are underrepresented relative to who's coming out of medical school. They're not interested in oncology. Is that what's happening? So we looked at an analysis of AAMC data specifically among U.S. faculty in rad-onc and med-onc departments, again, 1970 through 2019. And we looked again at proportions of women and individuals from these backgrounds. And here's what we found. Per decade, underrepresented medicine women faculty did proportionally increase, a very small percent, but nonetheless, proportionally increase by 0.1% in both rad-onc and med-onc. And non-UM women faculty also increased by a greater percentage in rad-onc and in med-onc. So again, we're increasing our representation in women, but it is still more so among non-underrepresented women. And unfortunately, when you look to the story for underrepresented men in both rad-onc and med-onc, no significant change over this entire time period. And in fact is heading in a concerning direction if you look here at panel B for men and women. And so the representation of women and underrepresented faculty in rad-onc and med-onc lower than the US population in 2009 and 2019, not surprising considering the data I just showed you. But again, we have to be thinking about what is going on within our oncology fields, at least these two in particular, that could be underlying this. So there are a lot of reasons and a lot of things that we cannot all tackle, and it's overwhelming to think about. One of these areas is certainly the socioeconomics, right? I'm going to keep coming back to that because we have to think about how the hidden costs of medical education, you get to medical school, great, awesome. Now, are you interested in a 5-year residency, a 6-year path to med-onc, some of which is research here, and then deferring that ability to pay off your medical school, your undergraduate loans. Perhaps you aren't going to have an opportunity to serve in the community from where you came. A lot of individuals who identify as underrepresented medicine want to go back to their communities. They have family obligations. They have reasons why they might be particularly interested in primary care and not pursuing specialties beyond that. And then there's aspects of exposure. Okay, socioeconomic factors also play a role in being able to do away rotations, to apply for competitive specialties, to have all those fancy things that get you into residency and fellowship. And again, these are just some of the factors involved. To the extent that exposure is the issue and lack of knowledge about these specialties, well, that is on us, and we have to address that. I want to just share with you that part of addressing that involves making sure that our current state of affairs, that the current residents we have in radiation oncology who are underrepresented feel supported. This is work we recently published, and Dr. Vanetta Williams helped lead this project with me and Dr. Elmore as senior authors. And this was a 23-item survey that we sent to all ACGME accredited programs in rad-onc through Arrow and through our subcommittee on diversity, equity, and inclusion, asking a variety of questions on institutional culture, support resources, recruitment, experience of bias. We had a decent, I would say, considering all of us are chronically, I think, exhausted with demands on our time, over a 40% response rate. All postgraduate years and regions across the country were represented. And we noticed some significant racial, ethnic, and gender differences. In particular, that white and male residents were more likely to strongly agree that they were treated respectfully by their colleagues and coworkers. And this was statistically significantly different than other racial and gender groups. And in fact, percent of residents within the race ethnicity group across the board who strongly agreed that they were treated agreed that they were treated unfairly, they perceived because of their race and ethnicity, are shown across the bottom, and you can see most dramatic for our Hispanic and Black residents. Now, again, these are small numbers, and when you get into the groups that identify as Hispanic and Black, again, smaller numbers yet, but concerning data that we are going to take into account and really try to come up with action items of how do we address this, right? Because I said we'll be problem-oriented, but we need to be solution-oriented, problem-aware, and solution-oriented. We have continued concerted efforts within our field for recruitment of underrepresented students to undergraduate medical education. We're doing well. We can be doing better in medical school, but we're doing well. So now we need to focus what's happening at the graduate medical education level. There are lots of mentoring and career programs that we are growing ASCO has had them, ASTRO has them, academic departments, individual academic departments have them. And I'm just going to throw up several resources for you from the AAMC. I have the little link at the bottom. I encourage you to look at these. There are toolkits, there are trainings, there are seminars, there are sessions you can attend within RADONC, within ASTRO, within the Radiosurgical Society, within ARO, ACRO, lots of opportunities for mentorship and for fellowship, and for opportunities to really have these conversations and have these conversations openly about why are individuals within our specialty feeling that they are not being treated fairly, and how do we get to the root of that? Now, you might be asking yourself, okay, a lot of this is, general patients and general workforce questions, but what's the impact on my practice, right? And so I think this is where health services research in particular has offered us so much insight. And, when you think about the work that's done, you find patterns of care, you find disparities, you look at the resulting compromise in clinical outcomes observed or suspected. And I hope where you get to with that are implications for modifiable behaviors. Otherwise, all you're doing is describing a bunch of things. You're not actually making a difference. So this is a far from exhaustive review. I'm just going to go through in our remaining time. And I'll give you all the typical caveats, and I encourage you to look at these references that, these are limited published data. They are US focused. Many of the things I'll describe will either be retrospective and single institution or database dependent, right? And the two databases that we're all quite familiar with, I imagine, in this room are the population-based surveillance epidemiology and end results registry, and of course, the National Cancer Database. And I just want to, again, throw out there that there are these references that will go through what the limitations are, because all of you, I know, learn to have a critical eye when you're looking at these. So with that being said, if you will afford me the luxury of, the caveats aside of why we can't, assume that these are all without limitations, let's at least see what lessons we have learned. And here's a great example. If you think about treatment guideline concordance, and lung cancer is a great example for that, we have large numbers from the NCDB, over 400,000 patients diagnosed in a relatively limited 5-year span, 2010 to 2014. And this work by Blom, published in 2020, actually looked at disparities in guideline concordance across all clinical subgroups and found that, so it's scary in and of itself across subgroups, okay, don't get me wrong, that only 62% of patients treated for lung cancer in this database were treated with concordance in the NCCN guidelines. And these are not the only guidelines one can follow, but if we take that as sort of a generally acceptable way to treat lung cancer, the fact that it is only 62% is in and of itself a finding. And what's really particularly important, again, is that, of the percentage of patients who received no treatment, which was felt to be, by the way, not concordant with guidelines, which would have argued that they should be treated. 16% of patients who did get treatment got less intensive treatment than the guidelines would have recommended. And again, this definition in this paper was particularly saying that patients were treated with conventional external beam compared to, say, stereotactic body radiation therapy, which was considered the more intense and more definitive intent treatment. The fact that this guideline concordant treatment was the least likely in older patients and among Black patients is where I think, again, we have a lot of work to do across the board, across all populations, but are these discriminatory behaviors happening? Okay, well, maybe the increasing age, the feeling is the patient can't handle it. Is that a bias on the part of the provider? Is that really a reason to preclude more intense SBRT? And then why would Black patients be offered this less? Why are they either undertreated or less intensively treated? And there are multiple corroborating studies. This is looking at the NCDB from a much broader time period, 2004 to 2015, over 800,000 patients with non-small cell lung cancer. And again, this discrimination is not only along racial lines, but we look here, rurality, living in rural areas was associated with a greater proportion of patients who are male, white, have more comorbidities, and who did not receive guideline concordant treatment. So I don't want to paint the picture that it's only along racial lines, but that this is where the intersectionality of poverty and or lack of access really play a role. And so again, the fact that this is the case, where guideline concordant treatment, which would be lobectomy or SBRT, was 53.4%. Now, I'm not saying the non-rural patients did great either, but this is really staggering either way, frankly. But this was statistically significant difference. And those rural patients had significant disparities in overall survival. This isn't just, oh yeah, it would have been nice if you got the guideline concordant treatment, but did it really make a difference? Yes, it actually literally did at every stage. It was most dramatic for stage 1, as you might imagine, because these patients were curable. And you can see the difference in absolute survival here, 61.4 months versus 50.3 months, simply by non-rural versus rural. Again, in this data set, they happen to be majority white and male. Different areas, different rural areas will have different composition. Early stage non-small cell lung cancer and SBRT, there is hope, okay? So I just showed you these data, but here's something exciting, which is that, again, this study, looking at over 300,000 patients over this time period, looking at no definitive treatment, so lack of guideline concordant care versus surgery or SBRT, that the proportion undergoing observation did decline over this time period. That's great news. We are making some progress. And actually, the decline was most dramatic among Black patients who had perhaps the largest improvement that they needed to begin with, that's where the most dramatic decline was seen. And conversely, that the likelihood of Blacks receiving curative treatment did go up the most dramatically compared to whites. And in fact, increased from 1% to 22% over this time period. The age-adjusted mortality in turn declined from 2004 to 2017. So these findings, while associated and not proven causative, are incredibly encouraging. What about for brain mets? Well, we know that if you do stereotactic radiosurgery alone, this requires stringent follow-up neuroimaging, right? And I bring up this very small single institution study because I really like it. It talks about patients, almost 40% of whom were treated at the safety net hospital associated with the academic medical center. And they looked at 153 of their patients in their institution consecutively treated with SRS for brain met over this period. And they, it's a retrospective analysis. I gave you all the caveats earlier. But what's really interesting is that the safety net hospital setting, if you were treated there, that was an independent risk factor for needing salvage neurosurgery, for developing neurologic symptoms, for developing hospitalization due to progression. And that more clinical visits actually protected against hospitalizations. Not surprising. Well, individuals at the safety net hospital were not getting those increased clinical visits for a variety of reasons. Perhaps they couldn't get time off from work. Perhaps they didn't have access to travel, or perhaps they weren't told to. More neuroimaging, also protective against death. All of these things we know. None of these bullet points should be aha moments. But what we do know is that there was a differential access to those clinical visits and to the neuroimaging, and it actually did make a difference. So again, access matters. Spine mets, moving along the journey, 23,000 conventional external beam patients compared to over 1,000 SBRT as part of their first treatment course for first presentation of spinal mets in the NCDB. And of the conventional external beam patients, the vast majority received 10 fractions. And there are associations between the patient demographics and type of radiation. And getting conventional external beams, so again, what we would consider not the ideal, we would consider SBRT for these patients for stage 1, for initial presentation of spine met, because they were eligible for it. Non-Medicare insurance or having private insurance, being Black, being older, residing again in perhaps a more rural or less populous region. Earlier in the treatment period, so the good news is that by the time you got to 2012, 2013, later in the study period, practice patterns were improving. But again, being treated in a non-academic facility also was a risk factor. And so again, all of these things telling us, why are these groups subject to this? And when we see patients who might fall into these categories, or if we're treating patients or seeing patients from a non-academic setting, was there something that would have been guideline concordant that they were denied? And how do we address that? How do we address that through education of the patient and the providers? Here's work that we did on prostate cancer and treatment non-completion. Over 166,000 patients with localized prostate cancer who had complete data. Median age was 70, vast majority of these patients were white. We noted that SBRT increased over the study period. Again, that's the story for many disease sites. We noted that SBRT was associated with lower odds of treatment non-completion. So really getting patients through as opposed to conventional external beam where the patients didn't finish the course as prescribed. Statistically significant difference. We also noted that Black patients were less likely to receive SBRT, just as I told you in lung, just as I told you in spinal meds. So put 1 and 2 together, higher rates of treatment non-completion in Black versus white men. Is this a modifiable thing by simply recommending the treatment that we know is associated with better odds of treatment completion? Again, assuming it's guideline concordant, which it would be in this setting. Impact of practice dynamics matters. Where are these patients being seen? This is work that was just published in January. Over 54,000 patients with prostate cancer across over 4,000 urologic practices. You can see the demographic breakdown of the patients here. Practices that had the highest proportion of Black prostate cancer patients also happen to have the lowest socioeconomic status associated with that practice. Also, those patients had the highest comorbidities. Again, this is all in line with what I've told you earlier. And again, Black patients had the lowest odds of definitive therapy and underwent less treatment than white patients in every practice context. So again, we're not talking about active surveillance where it was appropriate and staggering differences there. We're talking about when white patients were recommended to have treatment and did get treatment, the Black patient counterpart did not. What was interesting, though, is that within the practices where there was this critical mass and higher proportions of other Black patients and Black providers, there were higher treatment rates. So is there an influence, again, as we've said, of racial concordance with the provider? And if we have a staggering dearth of individuals who are Black, who are providing care, who are coming into oncology or going into urology or other practice settings, how is this impacting patient care and how do we address it? Here's work that was also published this January on the impact of looking at social determinants of health when we make these sweeping conclusions in our studies. I talked about Project Genie and scientific studies being done in drawing sweeping conclusions about populations that are underrepresented. What about when you actually account for socioeconomic determinants of health and look at cancer-specific mortality? This is a meta-analysis that looked at 47 prostate cancer studies. And you can see in all of the studies across the board that there was a significant percentage of both Black and white men, far more white men. And what the authors did is they compared prostate cancer-specific mortality and overall survival and incorporated an SDOH scoring system. So this idea of taking into account age, comorbidities, where do they live, what's their income, what are their insurance status, but also the benefits with that, and looked at developed three categories: high, intermediate, and low, meaning where they fell in terms of socioeconomic determinants of health and how this might impact the outcomes. If you reevaluate the studies with minimal accounting for socioeconomic determinants of health, or I should say disparities in that, minimal accounting, it looked like Black patients had significantly higher prostate cancer-specific mortality compared with whites. But when we looked at the same studies with greater accounting, so incorporating and adjusting for high versus intermediate versus low socioeconomic status, if you will, within this scoring system, actually, the prostate cancer-specific mortality differences were lower among Black men compared with whites. So again, raising this idea that we have to, perhaps, when we design some of our studies where we're looking at these mortality differences, think about how do we incorporate these factors in a more prospective way, and how do we make sure that we're not drawing false conclusions where in reality, there may be other explanations. This is work we're doing, it's not published yet, on the impact of Medicaid expansion on prostate cancer racial disparities. We're going to be looking at patients living in non-expansion states who did not expand Medicaid when able. And again, a lot of these states do have populations who are more likely to be Black and who are already more likely to be uninsured, compared to expansion states, which happen to be more likely to have Hispanic and Asian populations, have Medicaid coverage already, include metropolitan areas where these patients live. And again, these patients are more likely to receive care at academic center, reside closer to the treatment facility. So all these things need to be taken into account. But our initial findings are already that following Medicaid expansion, Hispanic, Asian, and Native Hawaiian and other Pacific Islander groups had no relative differences compared to whites in risk stage at presentation of a variety of cancers, as well as time to treatment initiation outcomes. So did they start treatment within 30 days, within 90, within 180, relative to the white patients in that same geographic region? So again, this is looking at prostate cancer specifically, but we are looking to expand this analysis and see, can we find that controlling for access makes a difference, at least in some way, in these groups. So what else does this mean for radiation oncology practice? In my final minutes, I would say the focus is not only on physicians and patients, but let's think about our staff. RadOnc is filled with a lot of individuals who help make the department run. And so we have to think about workers in general. Who are we employing and bringing into our practice? Who are our nurses, our therapists, our dosimetrists, our physicists, staff colleagues, as well as the faculty coming through in RadOnc and medical physics. This is a survey of over 3,500 workers. What do they most value and expect of their employers? More than 60% want their employers to take action on social and environmental issues like climate change, equality, and poverty. And this is a wonderful quote. Again, it's just pulling one quote, but there are many examples of this. A pre-med major who says that her workplace will likely be within either a hospital or medical office, and she hopes to see greater equity between men and women in positions of leadership, and that her workplace is be wholly inclusive and represent a diverse array of individuals. This is what the generation of workers, and again, this is a limited data set, of course, but this is what the expectations are of many individuals who want a career in healthcare and expect to see this change. So I say we focus on population-centered care and the population-centered data that I started this whole talk actually with the data on COVID, pandemic, and what Martin Luther King was trying to speak to. Focus on the patient in front of us, but then also think about the person. And I say this because it's the patient, but all of the things going on in their lives, all of those other factors about access and care and equity in income and being able to live in neighborhoods where they're not struggling against poverty, that's going to be critical to this. And I have to modify this proverb, which was in the masculine, to be a little more inclusive and say, they who have health have hope, and they who have hope have everything. And I think that is one of my favorite quotes, as is this one, that walls turn sideways are bridges. And I think, this is the modification of that earlier demographic that earlier graphic that we really want to think about. How do we remove barriers at every step for all of our patients and our colleagues? So I'd like to thank all of you. I'm sorry if I didn't leave enough time for questions, but thank you so much for having me here, to all my faculty and resident hosts, to Susan Brown for all of her coordination, and of course to all of our patients, staff, and trainees who inspire us every day. So thank you.
One or two questions really quickly. Yeah, so thank you so much. This is really inspiring. Could we open it up to, no question why you've been so valued as an educator. Would anyone in the room like to ask a question or two before we wrap up? I mean, I'll ask for one if you don't want to, but yeah.
What do you think we could do there as community?
Absolutely. No, thank you for that comment. I think this is where coming back to understanding the history of the legislation, that's why I started with the Hill-Burton Act and thinking about how federal funds, this was a bill that was signed by Harry Truman in 1946 saying, you can have federal government taxpayer dollars to build hospitals in areas of need. And yet that provision that allowed for the persistence of segregation that was in there, for that to be struck down, but nothing changed in behavior, reminds us that we can turn to our politicians, and we can turn to our leaders and say, you gotta fix this, you gotta fix that, but it does start with individual behavior and not looking the other way. So I agree that I think the emotional piece has to be part of the motivator, but it can't be the thing that takes over. I think we have to go to the data and say, look at the financial impact of this. Look at how this is impacting our community, and look at the fact that my patient outcomes absolutely could be better. My patient satisfaction scores, all of the things that get individuals who may otherwise not be interested in the emotional piece, or may be interested in perhaps relegating this to just an emotional argument, and always bring it back to the facts and say, no, actually, this is hitting everyone's bottom line, and it's hitting our impact on our patients. And these are undertreated patients that we could be addressing right now if we did X, Y, Z. I feel like that's the start. And to do that again, I bring up that whole workforce section in my talk, because I feel like we need that critical mass. And the generation coming after us is very much sees this as instrumental and fundamental to their training. They're not interested in learning about different formulas based on race and how creatinine changes. None of that is accepted now. Now it's about what are the differences, why are they there, and how is society responsible for those, not biology. So I feel like just bringing it back to the data every time.
So in the interest of people having other things to go to, I'm going to let anyone who wants to go, and invite anyone who wants to come up and ask, as well as more questions to come on. Thank you. No.